Hello and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenour and I'm joined today by thoracic surgeon Dr. John Lazar, pulmonary critical care physician Jessica Wang Memoli, and the nurse practitioner of patient navigation for the lung cancer screening and nodule clinic at MedStar Washington Hospital Center, Namita Puran. Today we're going to be discussing who is at risk for lung cancer, lung screenings, and treatment options to consider if lung cancer is detected. If you'd like to know more about lung cancer and when it's important to seek a consultation, then stick around, share this broadcast with your friends, give us a like to let us know you're watching. And if you have any questions for our experts, you can ask those in the comments below. Dr. Lazar, Dr. Wang Memoli, and Namita, thank you for joining us today. We appreciate it. Before we begin our discussion, could you guys tell us and the viewers a little bit about yourselves and the work that you do for MedStar Health? I'll start with you, Dr. Lazar.
Yeah, hi. Thank you so much for having us today. My name is John Lazar. I'm a thoracic surgeon, meaning I operate on every part of the chest except for the heart. And I manage a lot of the lung cancers along with Dr. Wang Memoli and Namita, and basically we form part of a group that discusses all patients. Not everyone's a surgical patient, obviously, but here to share some of the experiences that we've had and ways in which you can improve your own health. I came to MedStar 5 years ago, and I'm currently chief of thoracic surgery and co-director of robotics here at Washington Hospital Center.
Great, thank you. Dr. Wang Memoli.
Hi, my name is Jessica Wang Memoli, and as you've heard, I am the pulmonologist here at MedStar Washington Hospital Center, really concentrating on a lot of the interventional pulmonary procedures and really lung cancer. And like Dr. Lazar said, work closely with him, with Namita, and the rest of our multidisciplinary group to enhance our lung cancer care here at Washington Hospital Center. Worked with Namita on expanding and growing our lung cancer screening program, which we're going to talk a lot about today. One of my passions sort of within the pulmonary world. So I'm happy to be here to discuss one of these things that is of great interest to all of us here.
Awesome, thank you so much. And Namita?
Hi, everyone. Thank you so much for joining us today. So I'm Namita. I'm the nurse practitioner here at Washington Hospital Center. We deal with lung cancer screening and pulmonary nodule, as Jessica mentioned, and I've been here since 2016. I first worked in the medical ICU. I have experience with a lot of COPD patients and patients who smoke in general. So our patient population for lung cancer screening is near and dear to my heart. So I started the pulmonary nodule and the lung cancer screening clinic in 2020, and it's been really a wonderful experience. I love talking to our patients, something you really can't do with ICU patients who are very sick. So lung cancer screening patients, love it. And then I help patients navigate who, may have concerning findings on their lung cancer screening exams.
Great, well, thank you. And once again, we thank you all for joining us today and taking the time to answer our questions. So let's get into those questions. First of all, Namita, who is most at risk for lung cancer?
Yeah, and that's a great question. Everybody kind of wonders, what are the risk factors for lung cancer? Number one is a history of smoking. So, smoking accounts for up to 90, a history of smoking that is, accounts for up to 90% of all lung cancers. So definitely if you have a history of smoking, you are at increased risk of lung cancer. But also as time goes on and you get older, your risk of lung cancer also increases. So age and smoking would be the two top important risk factors for lung cancer. There are some other risk factors such as, history of lung cancer in your family, maybe a diagnosis of COPD or significant exposure to a carcinogen like radon or asbestos, and definitely secondhand smoke is also a risk factor for lung cancer.
And then what should a person do if they fit the criteria or, find out that they are more at risk for lung cancer, Namita?
Right, that's a good question too. So what are the criteria for lung cancer screening to begin with? As of the past 2 years, the criteria have actually been relaxed. So more people qualify now than they ever did before, which is great news. So if you are between the ages of 50 and 80 years old, and have smoked are you currently a smoker or having quit in the past 15 years, what they call a 20-pack year history. If you have those criteria, you're qualified for lung cancer screening. And, people always ask, how do I even measure a pack year history?
I was just about to ask that.
Right, yeah, like 20-pack year history, what does that even mean? So that would typically mean, strictly speaking, if you smoked, for example, 1 pack a day over 20 years, or maybe you smoked 2 packs a day for the past 10 years, even half a pack for 40 years. Many people come in and say, I smoked for decades. I quit, I started again. So in general, like even sporadic smokers may qualify with these expanded criteria. So, if you do qualify with these expanded criteria, the next step is to get a low dose CT. It's the only proven method of identifying lung cancer early. People do cancer screening tests for breast cancer with a mammogram, or like a colonoscopy for colon cancer. Lung cancer screening is one of those tests. Think of it as a yearly mammogram, but for a special group, our smokers in a certain age range.
Right. Okay. Thank you for explaining that. Dr. Wang Memoli, how is lung cancer detected?
So it can be a multitude of different ways. Obviously, as Namita was saying, one of the key ways that we're finding a lot these days is through lung cancer screening CTs. And so these are the people that Namita said who qualified for lung cancer screening CT. They get a scan and there's an abnormality on that scan. Now, there's a bunch of different kinds of abnormalities that can be seen. Some can just be maybe some emphysema because the person has a history of smoking, which can lead to some lung damage. And that's not really in line with concerns for lung cancer. Usually when we're thinking about lung cancer, it's a nodule or a mass is usually the words that are used on those scans. And those are the ones that raise our suspicion for lung cancer. So it's almost always detected on an imaging scan. Now that scan can be done, like we said, on a lung cancer screening scan for someone who has a history, but there are also people who get CT scans for another reason. So we've had patients who come in who have abdominal pain, and then they get a scan of their belly, and which shows a little bit of their lungs, and a scan is found for that. We have patients who get scans for their heart. So there's a lot of cardiac scans that are being done looking for coronary artery disease, and those can show abnormalities in the lung as well. And some of those can be concerning for cancer. People can have a cough. Sometimes there's symptoms, there's respiratory symptoms that might lead someone to get a scan, either a chest x-ray or even a CT scan, which would find either a lung mass or a lung nodule. And so those are the typical presentations that we see when we find something abnormal in the lungs that will lead us to a diagnosis of lung cancer. Now, just to reassure everybody, not every nodule and every mass that we see is necessarily lung cancer, but those are the ones that make us go, could it be? And those are the ones that we need to look at a little closer.
Right, thank you. And that actually, we had a question from one of our viewers she was asking, or they were asking, what are the symptoms of lung cancer? And then they also asked, lung cancer related screenings, do those use radiation?
So what I think I'll tackle the first one, and I think Namita, I'll send you to Namita for the second question. So the first one's, it's really tough because one of the reasons why we do lung cancer screening is oftentimes lung cancer people don't have symptoms. They can have something growing in their lungs, which is why things like lung cancer screening become so vital, because you can have a lack of symptoms. But if you have symptoms like shortness of breath that doesn't get better, weight loss, decreased appetite, coughing, cough that doesn't go away, coughing up blood. Those are some of the things that we think of that might lead you to consider lung cancer as a possibility of what's going on. But again, more evaluation usually needs to be done to look for actual cancer.
Okay. And then Namita, can you answer the other part of the question, asking if the screenings use radiation at all?
Yes, so low dose CT is special because it exposes you to a lot less radiation than a typical chest CT would.
Okay.
That's important because low dose CT for lung screening is actually indicated annually. So that means we're doing a scan every year to make sure that whatever we see in your initial scan, nothing got bigger, nothing is new. So we want to expose you to as little radiation as possible while still having a benefit. So, the low dose CT scanner takes a 3-day kind of X-ray picture of your lung using a very small amount of radiation. I read a statistic somewhere, it compared it to taking a round trip from here to Europe. That's the amount of dosage of radiation.
Okay.
A lot of people are scared about, any exposure to radiation, but it is a very small dose on the grand scheme.
Okay, thank you. And thank you for your questions. That also kind of goes into my next question for you, Namita, which was, in general, what is low dose computed tomography? Can you talk a little bit more about that again?
Yeah, so low dose computed tomography was based on the National Lung Cancer Screening Trials. They compared that to a regular chest X-ray to see what had the benefit of giving patients the more detail about if they had lung cancer or not. And then a low dose CT was found to have the benefit over the chest X-ray. So it is, typically a machine. It's still the same machine as a CT scan machine, but they use a smaller dose of radiation to kind of do from the top of your throat. We'll see your throat, we'll see your thyroid, your heart, of course, your lungs, all your stomach organs, including the liver, and then parts of the kidneys. So when we do this test, we don't need any dyes, no needles. You don't even have to take off your clothes, and no fasting or anything special. From the moment you step in the room to get the scan to when you leave, it's pretty quick. It's about 10 minutes and you'll be done. And depending on where you go for the screening exam, you could get your results within the week, sometimes 1 or 2 days. Yeah.
Oh, wow, okay. And so then how does someone get one of those screenings? Is that, something you just set up an appointment with? And if so, what doctor should you start with to get it?
Yeah, so if you find yourself to be qualified, or even if you think you may be qualified, maybe you had a sporadic smoking history, talk to your provider, whether that's your primary care doctor, maybe you have a pulmonary doctor or a nurse practitioner, and see, do I qualify based on my age, based on my smoking history? And then typically that doctor will go through something called a shared decision-making visit. They'll discuss what the benefits are for lung screening, what the potential drawbacks are for your personal case, and then they'll see if they can also discuss, if you're currently smoking, what are some ways we can get you to kind of get on that path to cessation and quitting. And then after all of that, they'll typically give you an order to have a lung screening exam done at a local radiology facility.
Okay. And then, Namita, what if someone is under the age of 50 or over the age of 77, like doesn't fit within the age range, but they fit the other criteria for lung cancer? Can they still get a screening? Can they still qualify? How does that work?
Yeah, actually, I wanted to add something about my last question too. If you don't have a provider, that's okay too. A lot of screening centers, and MedStar Washington hospitals, one of them will take you as a self-referral, and you'll meet with myself or another nurse practitioner to discuss your risks and benefits. And then if you come in and you're like with outside of that specified age range, 50 to 77 or 80, depending on types of insurance, we will assess if you have any kind of concerning symptoms. Like, Jessica had talked about, like that shortness of breath, new shortness of breath. Or maybe you have new chest pain that's super concerning, not related to any kind of heart symptom or weight loss or coughing up blood. Any of those alarming symptoms, you may qualify for a different kind of scan to assess if, this is something more concerning potentially for lung cancer as it stands. And, any kind of concerning symptom like that, we would encourage you to go to your doctor. But if, you have no symptoms whatsoever, and you are in that age range, I think most providers would offer you the opportunity to, see what ways we can get you to quit smoking. So, any kind of prescription medication, nicotine replacement therapy, there's, varenicline, all these options to help you quit smoking, because ultimately that is the best way to make your lung health optimized,
Right.
Yes.
Right. Thank you. Thank you for explaining that. I'm going to take a second and pause and tell our viewers, if you're just now joining us, thank you for tuning in. I'm joined today by thoracic surgeon, Dr. John Lazar, pulmonary critical care physician, Dr. Jessica Wang Memoli, and nurse practitioner of patient navigation for the lung cancer screening and nodule clinic at MedStar Washington Hospital Center, Namita Puran. Today, we're going to be discussing who's at risk for lung cancer, lung screenings, and treatment options to consider if lung cancer is detected. If you'd like to know more about lung cancer and when it's important to seek consultation, then stick around. Share this broadcast with your friends. Give us a like to let us know you're watching. And if you have any questions for our experts, please leave those in the comments below. Getting back into the questions, if a lung nodule is found, what happens next? And first of all, Dr. Wang Memoli, could you maybe explain a little bit more what a lung nodule is, and then talk about what happens after one is found?
That's a good question. And I know we sort of have been using the word, and it's always a good idea to know what we're talking about. So a lung nodule is really any little spot that is seen on a scan. It can be little tiny thing from a few millimeters. The scans are good enough to see, 1 or 2 little millimeter, like itty bitty little pinpoint things within the lungs that aren't normal, to a mass. And so a mass is really considered anything bigger than about 3 centimeters, which is, about the size of a $50. I don't know if anybody's ever seen a $50 these days, but that's sort of how they describe it. But and so, nodules are really anything that's sort of smaller than that. Masses are bigger than that. When you have a nodule, there's a range of possibilities of what that can be. Obviously, when we're doing lung cancer screening CTs in people who have a risk of lung cancer because they're smokers, there's always the bigger concern about lung cancer. But not all nodules are cancer. Nodules can be scars. So we have a bunch of patients who, get sent to us because they have a little spot in their lungs, sometimes itty bitty little spots, and they could be, you inhaled something during your however many years of life and your body created a scar. And that's all that you're seeing. They could be residual from a previous infection. So some people who've had pneumonias, or even sometimes just respiratory viral infections, COVID being the big one nowadays, right? That can lead to inflammation, which can then cause some long-term changes and scars. Sometimes nodules are what we call indolent infections. So again, if you ever get a scan and it says it's a nodule, don't automatically assume that it's lung cancer, but that may mean that another evaluation or further scans or other interventions may be necessary. And that's really where our goal is, for us to come in and sort of help you navigate that situation. So that's really what a nodule is and sort of what we do. Within our system here, we have what we call a multidisciplinary tumor board. So it's myself, it's Dr. Lazar, it's Namita, it's our thoracic radiologist, a thoracic oncologist. So people who specialize and sort of really pay attention to lung disease. And we meet on a regular basis to discuss patients who have lung nodules and really discuss what our next steps should be. Some of them are easy. We know, oh, you just need another scan in a few months, just to make sure things don't change. Some of them are so small, you don't even need to have any other interventions. But some of them need something more elaborate. Sometimes anything from a more involved kind of scan, something like a PET scan, which is a little bit like a CT scan, but has some extra technology that we add to it that gives us a little bit more information. Sometimes a biopsy is warranted, and that biopsy can be done by someone like myself, who can actually take a camera down into the lungs with some robotic technology and ultrasounds and different kinds of other kinds of technology to help us get out to that lung nodule and do a biopsy that way. Sometimes it's with the radiologist, where we send you to a radiologist and they kind of numb up your skin from outside and do a biopsy that way. Sometimes we send you directly to Dr. Lazar and say, you know what, this is something that we're really concerned about, and maybe a surgical biopsy or even a resection is what sort of is necessary. But we do it in a multidisciplinary way so that we're all kind of looking at it and we come to a conclusion. And I think that's one of the big things that we do here, is that it's definitely a multidisciplinary approach to all of our nodules and lung cancer care.
Great, thank you for explaining that. Dr. Lazar, are there different types of lung cancer? And if so, could you go over those different types, please?
Yeah, sure. I'm sure that's a question that people hear about when they find out that their nodule is positive for cancer. And you can break it down into several different ways. I think the easiest way to think about it is cancer that starts in the lung, and we call that primary lung cancer. And then there's other types of cancer, such as breast, colon, sometimes bladder cancer, prostate, that want to go to other parts of the body, and they go to the lungs. And we also take care of those. But they're much different types of cancer because they're related to different stages. And we'll get into what the stages are in a little bit. But let's just stick to primary lung cancer, since that's really where lung cancer screening is all about. And so there's something called non-small cell lung cancer, which is the most common type. And there are two types within that, which is adenocarcinoma and then squamous cell carcinoma. And they behave differently, and we treat them with medicines differently, and they react differently to that. But in the earlier stages, we treat them the same in terms of when we're talking about things like surgery and radiation. Then there's another type of lung cancer called small cell, which is a totally different type of family of lung cancers. Although it does start in the lung, it has a tendency to go to other parts of the body much quicker. And so that is treated medically, meaning chemotherapy or immunotherapy. And then there's another division within small cell called neuroendocrine or carcinoid. And that can grow in the lung at any age, usually people in their 30s and 40s, all the way up into their 80s. And so it becomes very important to get a biopsy once a nodule has been picked up on the CT scan in order to determine what type of lung cancer it is. And I know that Dr. Wang Memoli is going to kind of get into that soon. So, but there are several types.
Great, thank you for explaining that. And yeah, going back to, like you mentioned, the different stages of lung cancer, Dr. Wang Memoli, can you talk about those stages? How many are there, and the difference between each one?
So we stage lung cancer stage 1 through 4. So 1 being the sort of most localized, meaning we usually see a really small spot or nodule in the lung that ends up being cancer, but it doesn't look like it's gone anywhere else, even hasn't spread beyond that little spot, hasn't spread to any lymph nodes, hasn't spread to any other parts of the body. And then that's sort of where it's important to know what a lymph node is. So the way to describe lymph nodes, I always talk about people who complain about their glands being swollen when they have a sore throat. There's people who, oh, my gland, I have a horrible sore throat and my glands are swollen. Those glands are really lymph nodes, and everybody has them, and you have them all over your body. And it's sort of the drainage site for various parts of your body. And those lymph nodes can get big when they're trying to fight off an infection, for instance. So it's usually a bacteria or a virus that's causing that sore throat. But in terms of lung cancer, one of the first places that lung cancer will spread, when lung cancer is going to spread, are to the lymph nodes that sit in the center of the chest. So that's important, because if there's evidence of spread of cancer to those lymph nodes, then that then takes your stage of lung cancer up. So in general, stage 1 lung cancers are sort of isolated to just the spot in the lung that the cancer is seen, with no evidence of any spread anywhere else. The size matters, so the bigger it gets, the higher that part of stage goes. Stage 2, you start getting maybe a little bit of spread to one of the lymph nodes that's closest to that area of cancer. Stage 3 means it's sort of spread to more lymph nodes, but still stay sort of stuck within the chest. And then stage 4 is what we call advanced lung cancer, which means that it's either gone to the other side of the lung or to any other part of the body. So it's what we call metastasized, it's gone elsewhere. And really, it's important to know what the stage is. So, a lot of people say, oh my gosh, I have lung cancer, but there's a difference between a stage 1 lung cancer and what we do and a stage 4 lung cancer and what we do. And it's really important to sort of know what stage you are, because that helps us then determine treatment. A lot of people who find out that they have a lung nodule or something in their lung that could be lung cancer, their first thought is, what do I do? How do I get rid of it? And they want to jump to that treatment phase. And so that's a lot of patients that I see, in my job really is to make sure that we evaluate and know exactly what stage the patient is so that we can do the right kind of treatment. And the right kind of treatment can range. It could be that, you see Dr. Lazar and he takes you to the operating room and he, does a resection. And you may not need anything else except for some surveillance, which would be fantastic. You're cured. Your lung cancer is gone. Some of it may be that you'll need some chemotherapy or radiation afterwards, or beforehand, and then surgery. Sometimes it's no surgery at all. And sometimes we know we can treat, but maybe we're not going to cure you, but we can certainly treat. I mean, there's such a huge variety of ways for us to manage and treat lung cancer, which is why we emphasize stage so much. So we've talked about detection with lung cancer screening. We've talked about stage. That's really such a huge part of what we do.
Right. And then how do you diagnose those stages? Is it just, different testing, or does it kind of show up, after your initial screening? How is that diagnosed?
So that's really my one of the big things that I do as the pulmonologist is, a lot of people will get a scan and they'll be like, there's a nodule, what do we do? And they're like, send you off to the lung doctor, which is where I come in, right? So like I said, there's a bunch of different ways. And the first 2 steps that we have to do before we even get to the treatment part, which everybody wants to jump to, is write the diagnosis and the stage. And a lot of that can be done together. So one of the things that we talked about as a potential when a lung nodule is seen is maybe they need a different kind of dedicated scan, like a PET scan. What that helps do is look to see if whatever we're seeing is a lung cancer, has it gone anywhere else? If there's evidence that that lung cancer has spread, then it may be that a biopsy of a different area, not the lungs, is sort of what we decide to do. Mm-hmm. Sometimes it may be that, oh, yes, this looks like a lung cancer, we need to do a biopsy. And that biopsy gives us a diagnosis. So what's a biopsy? Well, biopsy really is us trying to get a little sample of the abnormality, right? So getting what we call a tissue diagnosis. So we actually somehow get a little sample of the tissue in that area. And that's where, and we can do that different ways. We can do that with the procedure where I basically take a camera and go into the lungs and go out to that spot. Sometimes I'm biopsying lymph nodes, sometimes I'm biopsying the spot itself, sometimes I'm doing both. Okay. It may be that we try and get some tissue through a radiologist. It may be that a radiologist will come in and numb up the skin over the chest wall and kind of go in and do a biopsy with a needle that way. Sometimes that diagnosis needs to be made by Dr. Lazar because it's so small or it's so far out there or it's all, it's so suspicious that the patient needs to actually go to the operating room and have part of their lung taken out that way. So there's a bunch of different ways to diagnose, and it's a little bit different for everybody about where we think who the patient should go to for that tissue diagnosis, where we actually have to get a piece of tissue. One thing to know is that unless we get a sample of tissue, a biopsy sample of some sort, we don't ever know for sure that it's lung cancer, right? There's a lot of things that may raise our suspicion on the pictures, on the images that we get, but we don't know until we actually have tissue and that says it's lung cancer. And it's usually one of the ones that Dr. Lazar has said it is one of the lung cancers, but we need tissue. So a lot of patients often come, oh, my doctor says I have lung cancer. Well, did you get a biopsy? And if the answer is no, then we don't really know, because there's so many different things that can show up as a nodule or a mass that aren't necessarily cancer.
Right. Thank you for explaining that. And Dr. Lazar, we mentioned this, there's different treatment options to consider for each stage. Can you go over those different options for us?
Yeah, sure. And I think, Dr. Wang Memoli did a great job in sort of describing the stage and describing why stage is so important for treatment. So if you think about stage 1 and stage 2, they're very local, meaning they're in a very fixed area in the lung or within the lymph nodes right around there. And so we would strongly consider a local therapy first. So in that case, it would be surgery, which is very good at taking care of things that are local, as well as it does an expansion of the lymph nodes. We remove all of those lymph nodes in that area to better understand stage, because there can be things that are microscopic disease that are not initially seen there or too small to be picked up by imaging. So doing a lymph node dissection is very important, and it really has no long-term outcome in terms of the patient feeling it or knowing it's there. When we get into stage 2, they're still considered a surgical candidate as long as their heart and lungs are good enough. But they're also, so just to back up, radiation is also another form of local therapy in addition to surgery. So if patients are not surgical candidates, they can be candidates either for stereotactic radiation, which is very finite and pointed, or proton therapy. So in that sense, it's very good. With stage 2, we're talking about where one of the lymph nodes is now positive. And so you need local therapy plus something that's going to give you more coverage. And in that case, we would be talking about chemotherapy plus or minus a newer kind of therapy, which is immunotherapy, for which there's many trials here at Washington Hospital Center. And then when we get to stage 3, the the lung cancer is probably in multiple places within the lymph nodes or within the lung. And in that case, you're going to have a discussion with this multidisciplinary team about, well, should I be getting something treated up front with either chemotherapy and radiation, followed by surgery if I'm a surgical candidate, or should I be just treated with chemotherapy and radiation, and in fact, surgery is not on the table? And then obviously, if it's stage 4, which means that it's gone to another organ system, we're truly just talking about medical therapy, whether it's chemotherapy plus or minus immunotherapy. And so, one of the exciting things about where we're headed in is that we have a lot of hope for people with more advanced disease than we had before. And I think someone was asking about, what do I have symptoms or not? If you have symptoms, it's generally a more advanced disease. And unfortunately, this is where we're capturing most of our patients. And so this is part of the big push for early diagnosis, screening, so that we have better options and more options for treatment.
All right, thank you. And that, everything we've talked about sounds like there's a lot of different steps you have to go throughout this whole process. And I know, Dr. Wang Memoli, you mentioned a multidisciplinary approach to the whole process a little earlier. So what providers will be or can be involved, if lung cancer is detected?
Oftentimes, people will need to see someone like me, a pulmonologist, and usually someone who can do some of the biopsies. There are times that you'll need to see a radiologist, depending on if we decide to do a different kind of biopsy. There's a chance that you'll see someone like Dr. Lazar, a thoracic surgeon. And then you may or may not even need to see a thoracic oncologist. So there are some patients, for instance, who have very localized disease. Dr. Lazar takes care of them, and you don't even need an oncologist because hopefully the lung cancer is taken care of, it's cut out, it's gone, it's in the trash, and you don't have to think about it again. So, it's pretty varied, but those are probably the key players are myself, a surgeon, an oncologist, and then a radiation oncologist, who is someone who would administer radiation, like Dr. Lazar was saying, sort of localized radiation to an area if a person is not able to undergo surgery, or if radiation's indicated based on the stage. So those are really the key players. And obviously, if you started off with Namita, because she did a lung cancer screening CT, then you would see someone like her. So those are probably the key players. And again, here at Hospital Center, these are the key players that meet in our tumor board every week. And so it's really to get the opinions of all the people who who could be involved in care.
Okay, thank you. We have two questions from our viewers that I'm going to kind of lump together because they are kind of asking the same thing. One is from Caitlin, and she asked, can people who don't have a history of smoking get lung cancer? And then the other is from Annie, who's asking if she would qualify for a screening because her dad had lung cancer, but she's also never been a smoker. So does that have, any play, whether you smoke or not? I know that, you said smoking is, a risk factor, but if there's a history and you're not a smoker, does that still have an effect on your risk level?
So I'll take this question because it's for screening. So based on family history, it's in addition to have you a smoking history and are you in the right age group? So what the Centers for Medicaid Services and the United States Preventative Service Task Force, which is the governing body for screening, has determined is that you have to have a smoking history in order to qualify for lung cancer screening. So insurance will not cover it unless you have a smoking history. But it doesn't mean that you can't be screened for other cancers. For example, if you have a history of cancer in your family, and definitely bring it up with your provider that you have a history of lung cancer in your family, because you potentially have had secondhand smoke, and maybe you have new symptoms that you are concerned about. So I would say that talk to your provider, but strictly speaking, the history of smoking and a 20-pack year history more specifically is a requirement for lung cancer screening.
Got it. Okay. Thank you for explaining that. Oh, go ahead.
I was just going to add that, while smoking is the biggest risk, raises your risk the most for lung cancer, there are certainly a lot of instances where people get lung cancer who've never smoked. I think the big one that's been in the media recently is Kathy Griffiths, who apparently had her lung cancer resected, and she's a never smoker. And I always use the example of Dana Reeves. For those of you who are older, remember Superman, Christopher Reeves, his wife also had lung cancer. Neither of them are smokers. So it's certainly something that can happen in non-smokers. And it's a little bit tough because, like Namita says, we don't have dedicated screening for those, that patient population. But it can happen. And sometimes, it's sort of like cancers in other areas that don't have something that increases your risk. It's unfortunately something that can happen and we see. But again, symptoms are really what then become a little bit more important, and really being vigilant when anything pops up that would make you concerned about that.
But there's also, I'm just going to jump in. There's also other exposures that we did not discuss. The number 2 exposure is radon. So a lot of people who don't know about it, who spend a lot of time in their basement, especially in places, northern Maryland, southern Pennsylvania, where there's a lot of radon in the soil, and never had their homes tested or mitigated. They're at increased risk as well. Also, certain occupations have higher risk. Obviously, those with carcinogens that are inhaled over and over again over many years, in terms of working at a quarry or a coal mine, working in some aspects in aviation and in the car industry, also in the military, around those types of things. There's also HVAC workers are at high exposures for asbestos, which can be synergistic with tobacco use and has a greater than 100 times increase in development of lung cancer and mesothelioma, which is a cancer of the lining of the lungs and the chest wall. That's also concerning. And also, I think this was sort of mentioned, but not really mentioned, is being in the house with these people who bring these particles back home from their work, and then it's on their jackets and their pants, and it's in the house. And then over the course of many years, the children and spouses of these people inhale this, along with the secondhand smoke, puts them at risk. But I think Namita, has said it multiple times. Again, we do not have, the task force has not given us exact guidelines on these people who are at risk. But what I really wanted to bring up to the group is, to the Facebook group who's listening, is you should go to your healthcare provider, whoever it is, and bring up these questions and say, like, hey, am I at risk? Should I be worried? And we can even start with a chest x-ray. It doesn't always have to be a low dose CT, but then, as Namita also said, you can self-refer yourself in to a group of people who think about these types of things all day and really know how to navigate these subtleties.
Right, thank you. And I'm glad that you hopped in and mentioned asbestos, because that was actually another question from one of our viewers, was asking if being exposed to that could cause lung cancer. We also have another question from a viewer. How can you tell the difference between a TB exposure and lung cancer?
So it's not just, you can't know just from pictures. I think I mentioned once before, sometimes we actually need to get some tissue sample. Usually there's things, if someone's had exposure to tuberculosis, they've traveled to various TB, elevated TB endemic areas, then that does raise the risk. If you've been incarcerated, lived in a group home, sometimes that might be an indication that your risk of getting tuberculosis is elevated. And really the only way to figure that out, again, is a biopsy, a tissue diagnosis, which can be done, as I sort of mentioned, in various ways. But yes, it's usually not just a picture that can tell you. There are some things that can make you think more tuberculosis versus other, versus cancer. And then there's actually other infections within the family, what we call the mycobacterial family, that which is the same family that tuberculosis is in, but not actually tuberculosis. So it can get pretty complicated. But again, to remember that it's usually just a picture, an image from a CT scan, a chest X-ray, a PET scan is usually not enough to for us to know for sure.
Got it. Thank you. And thank you for your question. Thank you to all of our viewers for their questions. I have one final question, unless there's anything I missed that you guys want to add real quick. But my last question for you guys is, what message do you want our viewers to take away after watching this broadcast? Dr. Lazar, I'll start with you.
Yeah, no, I have an important message, and I think it's, you don't necessarily have to be someone at risk for lung cancer who's on this stream today. But if you love someone or know somebody who's high at risk, don't be afraid to remind them, like, hey, I know you want to smoke, but let's go to the doctor. Let's talk about getting a lung cancer screening, and then we can think about quitting. And not to shame them or feel embarrassed. It's a really hard habit to kick. And I also send that same message out to all the primary care doctors who are seeing their patients, because we're not meeting the needs of our citizens in this country, and we should be screening more people who are at risk, whether it was 10 years, 5 years ago, or they had their last cigarette 5 minutes before coming in the clinic. And I think we really have to raise the awareness of it, and we're all part of it. And it doesn't matter if you're an orthopedic surgeon or you're the tech taking labs, like, we all can remind people gently that this test saves lives, that it's covered by, your insurance, and that, it's painless. So I think that would be, my message. So I appreciate you letting me go and answer that.
Awesome. That was great. Thank you. Dr. Wang Memoli.
I would say that don't jump to conclusions. There's a lot of different things that can give you abnormalities on a scan. We are here to help you figure it out. We are here to point you in the right direction, get you to the right people to take care of whatever it is that we find. We have the multidisciplinary care here to discuss, to get you to the advanced care that's needed if it ends up being lung cancer. We have some amazing, we have an amazing thoracic oncologist and a multidisciplinary team to discuss that. And if it is lung cancer, it's not the end of the world. There's so many advances that we've made in lung cancer care that, it used to be something that didn't have the same kind of outlook, and that's changed in the last 10 years, and it's pretty amazing.
Great, thank you. And Namita, I'm sorry, you have to go last, and hopefully you have something different to say.
All the important points have been said, Sarah. But I want to reiterate, Dr. Wang Memoli mentioned that, being diagnosed with lung cancer is not the end of the world, and especially if you are keeping up with your screening, if it's something we found it super early, potentially stage 1 or stage 2, survival rate, is as high as 92% in those stages. And you get it taken care of when we can do that early on. And then I also want to highlight what Dr. Lazar mentioned. Screening rates for lung cancer are superbly low. So we're looking at like 6% compliance in people who actually qualify. And that could be, a lot of things. Maybe like Dr. Lazar mentioned, nobody told you about lung cancer screening. Nobody told you qualify. So it could also be, like fear. Everybody's a little bit afraid to find out, but finding out early when we could do something is preferred over later stages where, your options for therapy are limited. Potentially, your quality of life will be severely impacted. Those things, someone once, I think the American Cancer Society did a survey, and they said like compliance for breast cancer screening was like 50%, and like colorectal cancer was 63%. So these huge numbers, and lung cancer is still one of the most prevalent cancers diagnosed, potentially poor mortality if we find it later. So, the population that qualifies for lung cancer screening is, one of the people who will benefit the most from screening compared to any other type of cancer screening. Not to say that don't go get the other cancer screenings. All cancer screenings are important. It's going to affect, cancer screenings are really good because they can identify cancer early when you have no symptoms, and you can go on and have your great quality of life for as long as possible.
Right. Thank you. Those were all great takeaways for our broadcast. So that wraps this broadcast up. Thank you to our viewers for tuning in, and to our experts for joining us and answering our questions. We appreciate you all taking time out of your day to do so. If you would like to learn more about what we've discussed today, you can visit our lung cancer screening page, which we will be posting the link to in the comments. So thank you again for joining us, and we will see you next time.